I just want to reinforce, the point that Ken Chang just made with regarding to collaborative working relationship between our gastroenterologist and GI surgeon. So here at UCI, we have 4 GI surgeons, and we work very closely with our GI colleague on a variety of management of the foregut issue, and reflux is just an example of one of them. The way the patient gets to our center is, through our gastroenterology colleague. I mean, because the first thing is first, you have to have the diagnostic evaluation. You have to get the appropriate test before you provide any surgical option. So a lot of our patient sees Ken Chang and his colleague, for evaluation prior to even coming, for a surgical consultation. And a lot of these patients these days have do a lot of research into their condition, particularly hiatal hernia and reflux issue. They're very savvy with regarding to treatment option that's available. And one thing I've heard, and Ken, you can correct me if I'm wrong here, is a lot of these patients do worry about gas bloat symptom, the issue of a Nissen fundoplication. So TIF provides a good option for these patients. However, in certain scenario, these patients do have a hiatal hernia. That can be an issue for the TIF procedure because the hiatal hernia needs to be fixed. So as a surgeon, what I think we should do is to work collaboratively with our GI colleague, because the hiatal hernia repair can be done relatively expeditiously. We can do that procedure quite quickly. And I think, having a concomitant TIF procedure with a hiatal hernia repair just makes sense. It can be done at the same setting, and the patient can leave within 24 hours. So I think it's definitely a good option to consider for a patient, with reflux and hiatal hernia repair. I think it's important to mention that, anti-reflux procedure in this state is a multidisciplinary approach. It's not just a surgical approach, it's not an endoscopy approach. These day and age, I think we have to look at it at multidisciplinary. So it's very critically important for a surgeon to work with our GI counterpart to offer the best treatment option for the patient. And this is just a single example of what we do here at UCI. We're planning to approach this, concomitantly, whereby we perform the laparoscopic procedure, reduce the hiatal hernia, and perform the anti-reflux procedure transorally, all in the same setting. So certainly that will provide the best patient care, in a single hospitalization for the patient.
I think the TIF procedure also underscores how important it is to have this multi-specialty, multidisciplinary approach to foregut diseases, to esophageal diseases, to heartburn, in that it's a spectrum, whether it's heartburn or Barrett's or early esophageal cancer. As gastroenterologists, we need to realize what things we can do, what things the surgeons can do. They need to know what we can do. And case by case, it can vary. I can take it to a certain point, and then takes over, or he can do certain things, and then I'm back on, or we're working together. So there's this ebb and flow between specialists that is seamless, and I think that's really the modern way to take care of these patients.
So with regarding to the treatment option, you kind of stated 3. So either hiatal hernia repair with a concomitant links, hiatal hernia repair with anti-reflux operation like a Nissen fundoplication, and the last laparoscopic hiatal hernia repair with a TIF procedure. Can you just kind of go over, selection process of how, you decide with regarding to which treatment option is the best for your patient?
Yeah, so I have a careful discussion with the patient, and the considerations are the patient's age and the durability of the operation. For example, this patient is relatively young. She's 55, and so we're looking at 30 years in front of her. And so if we consider a Nissen fundoplication with a durability somewhere in the 8 to 10 year range with anticipation of a possible redo. We know that the redo success rate is lower, so that is certainly a consideration. A LINX procedure perhaps may be slightly more durable because these are earth magnets. But then we get into the issue of MRI compatibility, and with the years ahead of her, the MRI magnetic strength Teslas will go from 3.0 and up, and so we may have an issue with demagnetization of the device.
And also, there's an issue of authorization for the procedure at the current time also.
Correct. Yeah, authorization is not uniform for the LINX procedure. And then there's also the issue of gas bloat after an instant fundoplication. That has perhaps the highest gas bloat rate. LINX may be slightly less, and TIF much less. So with the TIF procedure, we have good durability data out 5 years. We don't know where it goes after that, but it allows maximal flexibility in that in 5 years plus, we can certainly do some more TIF tightening. And certainly she can have surgery in the future, so it doesn't burn any bridges. And to go back in for a reoperation with a TIF is easier because you don't have to worry about taking down a wrap. As a gastroenterologist, when patients come and I explain the different options, they gravitate towards the TIF procedure. Maybe they've heard about it or they've read about it. And they're coming to me saying, can I get a TIF? Or after explaining the options, they say, oh, I really want the TIF. And I say, wait a minute, we need to first do the proper evaluation with endoscopy and pH monitoring and see if you're a candidate. And if the situation arises and they have a Hill grade 3 and a 3-centimeter hernia like this case, it's a bit of a downer, both for me as a physician as well as the patient, because now all of a sudden they're getting handed off to a surgeon who's going to do something very different, and the patient's level of comfort may not necessarily be there. They've even asked me sometimes, oh, can you come into the OR also? So there's that attachment that goes away when we see the anatomy is not conducive to TIF alone. And that's why having a colleague, a surgical colleague, who also understands that GERD is truly on a spectrum and patients can be in these in-between situations. Now the option of doing a concomitant procedure, the patient feels so much better because they can still get their TIF, but we are so confident that now with a hernia repair plus TIF, we've given the patient the best possible outcome. We've worked together towards that goal, and the patient is extremely satisfied. I've had surgeons ask me, hey, when I'm in there and I'm doing my hernia repair, I'm already there, so I might as well just finish with the fundoplication or just put in a LINX. How would you address that perspective?
Well, I think we talked about the LINX previously. There is issue of insurance coverage currently for the LINX, and also particularly for a patient, with a lot of, spine issue or some condition that require frequent MRI, I really, suggest that the patient do not get a LINX, I think the dysphagia rate with the LINX is higher than a Nissen fundoplication or even the TIF. So you do have to worry about that a bit. And with regarding to the fundoplication, it's still a very good option, no doubt. But I think what I'm alluding to is that a lot of these giant hiatal hernia repair, we do have foreshortening esophagus, which really limit our option. That's where I think the role of TIFs in combination with hiatal hernia repair really comes into play, where you don't have a good option for an anti-reflux procedure because of the shortened esophagus.
Hi, my name is Ken Chang. I'm a gastroenterologist. I'm the chief of the GI division and director of our Comprehensive Digestive Disease Center here at UCI Medical Center.
Good morning. I just want to welcome everybody to University of California Irvine Medical Center. We're going to talk about a case today. My name is Nguyen. I am the chief of gastrointestinal surgery here, and I'm also the chair of the Department of Surgery. And today we have an interesting case, and I'll turn it over to Dr. Chang here to introduce you that case.
Thanks, Nguyen. The patient is a 55-year-old female with a long-standing history of gastroesophageal reflux disease who has been also on long-standing PPI double-dose treatment, but has had breakthrough symptoms of regurgitation almost on a daily basis. Her workup started with an endoscopy, which showed a 3-centimeter hiatal hernia, and on retroflex had a Hill grade 3 anatomy. The pH probe was then placed in the distal esophagus, and a 96-hour study was performed, and it showed that her esophageal acid exposure time was 6.5%, and she had both upright and supine reflux. With that information, we sat down again and discussed her options: a laparoscopic hernia repair with Nissen fundoplication, a laparoscopic hernia repair with Link's procedure, a laparoscopic hernia repair with concomitant TIF procedure. After some discussion, the patient opted for the concomitant laparoscopic hernia repair with TIF procedure.
Can you just mention real quick about the best data currently for the TIF procedure, just irrelevant of the higher repair, just about the TIF itself?
Yeah, so if we roll up all of the clinical trials, and we have a number of level 1B randomized controlled trials, it shows that at all comers, 72% of patients can have dramatic relief of symptoms and completely off their PPIs at 1 year. The efficacy is strong. It's not as high as a Nissen, but I think for most patients, it's sufficient enough for them to be able to have relief of troublesome symptoms, getting off the PPI, which is a concern for many patients, and with the flexibility of options in the future.
So Ken, before we jump to the treatment plan, she also had an upper GI, and it looks like a relatively large paraesophageal hiatal, but you described on the endoscopy it's only 3 centimeter, but certainly the Hill grade 3 kind of tells you that this is quite large hiatus. So when you do these type of measurement, do you take into account between the Hill grade versus the hiatal distance? How do you take that into account to kind of give you an understanding how big this hiatal hernia is?
Absolutely. We're oftentimes fooled, or we underestimate the severity of the hiatal hernia if we only look at the vertical length measurement. The width of the diaphragmatic hiatus opening is as or more important than the length, I believe, because with a Hill grade 3, you're just getting a snapshot of the hernia during endoscopy. It could be in its resting state, it could be sliding significantly higher. And so that is a dynamic situation. So I put a lot of weight on the Hill grade.
Okay. That's kind of important because, the indication for TIF procedure, you can actually perform that procedure up to 2 centimeter hiatal hernia. So, in this particular case, you're describing as 3 centimeter. It doesn't seem to be that drastic. So for a certain provider, maybe they think, hey, I can do a TIF procedure on this particular patient. But based on the upper GI study, I think it kind of proven us otherwise that this is a relatively large, paraesophageal hiatus.
Absolutely.
One thing that you haven't mentioned is that, for a patient with a large hiatal hernia, there is an issue of foreshortened esophagus, which is not an uncommon event for these patients with very large hiatal hernia. So what are the strategy options, for a patient with shortened esophagus?
You're right. In patients with chronic GERD and Barrett's esophagus, so this patient had 1 centimeter of Barrett's esophagus, you can fairly well predict that they'll have a foreshortened esophagus, which then makes recurrence of a hiatal hernia risk higher. So in that situation, the TIF procedure may have an advantage. There are other emerging endoscopic approaches for patients who have failed prior nasal fundoplication because of a foreshortened esophagus. But what are your thoughts about the patient with the foreshortened esophagus?
Well, intraoperatively, we can only do so much with regarding to lengthening of the esophagus, certainly, and, significant mobilization, and we do that in all cases. So we go through the hiatus and essentially mobilize the esophagus for approximately 7 or 8 centimeters into the mediastinum. We retract all the mediastinum pleura. That is the best way to mobilize the esophagus. But despite significant mobilization, some of these patients with large hiatal hernia, they just have a very foreshortened esophagus, and we cannot get the required length we need. Normally, you need 3 centimeter intra-abdominal esophagus to create a adequate fundoplication, and some of these patients, you don't have that. So that's where the issue lies with regarding to an anti-reflux procedure and working with these patients with very large hiatal hernia. In those scenarios, the only other surgical option available is a collis, gastroplasty. The laparoscopic collis gastroplasty is being done at certain center, and it can be done relatively safe, but nevertheless, it increase the magnitude of the operation and also the risk of the procedure. And just remember that a lot of the patient, with these giant hiatal hernia are in the elderly. One of the risks is really leakage at the level of the staple line. So certainly, you have to take the risk and benefit of this procedure into account when you, approach a repair like this.
Initially, people have some concern about just the logistics of coordinating GI endoscopy and GI surgery together. We find that it flows quite seamlessly. We have the endoscopy cart ready. The laparoscopic hernia repair, I think, goes as usual. And then as they're closing, we just move the endoscopy cart and do the TIF within minutes of the hernia repair. Today we saw that the hernia repair took less than an hour and the TIF took 25 to 30 minutes. So the entire procedure went extremely smoothly and quickly.
I think the biggest hurdle is certainly scheduling between certainly the two of us. You have to be in the same room the same day. But once you pass that hurdle, I think it's relatively seamless, like you said. The laparoscopic portion is normally less than an hour, and the patient remains in the supine position. So really, no need to change any patient positioning. General anesthesia has already been established for this, for a hiatal hernia repair. So upon completion of the laparoscopic portion of the procedure, we move directly to the endoscopic phase relatively quickly. So it is a very seamless procedure.
All we do is tilt the table slightly, tilt the head slightly. There's no repositioning of the patient, and we go. What about mesh? Today you placed a mesh. Does that help in terms of the recurrence rate?
Well, the randomized trial, looking at mesh versus no mesh, they use a biologic mesh, and what they found is that there is improvement in the earlier recurrence rate. At the 5-year mark, however, the recurrence was actually similar between with and without the mesh. But with that being said, I think the type of mesh we use these days is, I think it's a little bit improvement from the prior mesh. It has more integrity, and you need some type of integrity in mesh to prevent these type of recurrence, and it provides a scaffold for tissue ingrowth to develop in that region. So I like to use the mesh. The mesh we use is bioabsorbable, so I don't like to use synthetic mesh in that region just because you can cause erosion into the esophagus, which has been shown previously, so we like to use the bioabsorbable.